Greetings and welcome to this educational activity focused on the evolving role of PARP inhibitors in the frontline and recurrent treatment of ovarian cancer. My name is Brad Monk. I'm a gynecologic oncologist, and I'm joined by my colleague, Dr. Lindsay Wilmot. Both of us are on the faculty of Creighton and University of Arizona here in Phoenix. We are part of the U.S. Oncology Network, known as Arizona Oncology. It's really my pleasure. Thank you. I'm going to call you Lindsay, if that's okay, for being with me today.
Of course, that's okay. Thank you for having me.
It's really exciting what the community has done in ovarian cancer in the last 5 years. We're going to talk about PARP inhibitors. We have 7 FDA-approved indications for PARP inhibitors today. We will likely have many more in the year 2020. And we already had bevacizumab. So this is really, really an exciting opportunity. I think a lot of it is rooted in what we understand now about the biology of ovarian cancer, and really we mean peritoneal, ovarian, and tubal cancer. And we also have partitioned it into different histologic types. Generally, we're going to refer to high-grade serous ovarian cancer, which is 85% of tumors, but certainly there are low-grade mucinous and clear cell subtypes. And it's not just the clinical biology, but it's the molecular biology.
Yes.
We've learned these high-grade serous tumors, the most common molecular abnormality is P53. It's a tumor characterized by genomic instability, genomic chaos. And now we've learned, of course, about BRCA. Tell us about the BRCA gene.
Right, so BRCA is certainly probably the most characterized of our homologous recombination genes and proteins. So what does that mean? Homologous recombination is perhaps the most perfect form of double-stranded DNA repair. So our cells, they're ticking along every day. They have errors that occur, and we have a number of types of cellular machinery that they depend on. Homologous recombination certainly allows our cells to repair double-stranded DNA breaks with very good loyalty to the actual DNA code. There are other types that the cells can rely on if that cellular repair mechanism is broken, for example, non-homologous end joining or other types of DNA repair, but certainly homologous recombination is the most important.
So we're going to call that HRD, homologous recombination deficient, or HRP, proficient. So either you can do it or you can't. Deficient, you can't. Proficient, you can. And again, the sister chromatid lines up to the homologous sister chromatid, and the double-stranded chromosomal abnormality is fixed. And you said that there are lots of genes involved. One is BRCA, central to that, and we test all patients for germline BRCA, but you can have somatic BRCA.
Absolutely. You know, nowadays we recognize how often these errors occurred, and even perhaps 5-10 years ago we didn't realize this. So, you know, there used to be a strategy, perhaps look into the patient's age or take family history into account, but now we realize that is not true. Every single patient who comes in who's diagnosed with an ovarian cancer needs to be tested.
Everyone, and we can also test for beyond BRCA, but it's a tumor test. So you have the germline testing and the tumor testing. The tumor testing is also for BRCA, like the blood, and if it's in the blood, of course, it's in the tumor, but we can test for beyond BRCA, this homologous recombination repair opportunity. There are 2 commercial tests, and we're not going to get into them, but those molecular tests are important because they have to do with PARP inhibitors, and that's what we're here to talk about.
Yes.
So tell me the relationship between PARP inhibition and double-stranded DNA repair, which you call homologous recombination.
Sure. So PARP is called poly-ADP ribose polymerase, PARP. It's a protein that's responsible for base excision repair, so that's a single-stranded DNA repair mechanism. Yet another of the many types of repairs that are happening all the time. If we can inhibit that protein, then we'll start to see more single-stranded breaks. And with that accumulation of single-stranded breaks, then we can see double-stranded breaks. So for those cells that cannot fix those double-stranded breaks, that are relying on these less perfect forms of repair like non-homologous end joining, then this can be catastrophic. They can start to have too many repairs that build up, and then the cells are targeted for death or apoptosis, which is exactly what we would want in a cancer cell.
Yeah, I love it. So if you have PARP inhibition, nothing happens. If you have BRCA, nothing happens, or BRCA-like genes, HRD. If you have both, synthetic lethality, the cell dies.
Exactly.
So based on that biology, thank you, the world changed on December 19th, 2014 with the approval of the first-in-class PARP inhibitor, olaparib, in these molecularly defined subgroups, BRCA only, germline only, and then ultimately later on we got rucaparib, germline, and somatic treatment, and then the most recent treatment was niraparib with the HRD molecular signature. Now I get asked all the time that those 3 treatment indications, right, since 2014 over the last 5 years, olaparib, rucaparib, and niraparib, that the response rates are different even though they're all molecularly defined and they're between 2 and 3 prior regimens. Why are they different?
That's a great question. But I think a lot of the times we see differences in clinical trials. Some of that may be because of the trial design.
Yeah.
So certainly those trials were not designed the same way. Also, you have to take into account some of the other perhaps important things that allow us to know who may or may not respond to PARP inhibition. One of those things likely is number of prior lines of therapy. So when we were first looking at PARP inhibitors, as you well know, we were looking at these patients who had been treated with insane numbers of lines, and we weren't seeing any response, and that's probably because of some degree of resistance. That becomes accumulated as patients are exposed to more treatment. Similarly, there is a difference in how well patients may respond. Certainly, all patients may be candidates for PARP inhibition at some point in their treatment, but we know based on trials that those patients who are BRCA mutants are most likely to be the most extreme responders, followed by those patients who have homologous recombination deficiency or HRD, and then last, probably those who are wild type with functional protein status.
So number of lines of therapy, molecular signature, you said, and then the most recent observation is platinum sensitivity, which is also what you said. So you can't take these treatment single-arm clinical trials and compare them, which vary between 54 and 24%, and say, oh, this PARP's better than the other, because the populations are not the same, and it's not just the molecular signature, although molecular signature counts.
It does.
And one of the things that I think is the epiphany that this platinum sensitivity, although not a molecular biomarker, is a clinical biomarker, because platinum adducts break the DNA just like PARP inhibitors do, and if you can't repair a platinum-induced double-stranded break, you can't repair a PARP inhibitor-induced double-stranded break, so there's a sort of similarity and opportunity, and so that led to 3 other indications. So we had 3 treatment indications based on single-arm trials only in BRCA, germline, olaparib, BRCA, germline and somatic rucaparib, or this HRD molecular signature niraparib, and then 3 platinum-sensitive maintenance indications. So tell me about that sort of concept and how that developed in the platinum-sensitive maintenance opportunity.
Sure. So obviously, just to start at the basics, what is platinum sensitivity? So that's a patient who's received a platinum-based chemotherapy for her recurrence, for her initial treatment. She has had a good response to that, and she's made it at least 6 months before she has evidence of disease return. So if the patient has had that parameter, most practitioners would retreat with platinum. And so then if the patient has response again, that is when these trials come into effect. So these patients have to have had platinum-sensitive recurrent disease and had at least partial response to their platinum-based chemotherapy to enroll. And all 3 of the trials showed that patients responded to these PARP inhibitor maintenance with improvements in progression-free survival over placebo. All of them were placebo-controlled. And that was a statistically and clinically meaningful difference in improved progression-free survival. And I think the very important thing to note is that these trials included patients who were BRCA mutants and those who were not.
Beyond BRCA, yes.
Correct. And so, there is certainly a difference perhaps in the improvement in progression-free survival, but all patients, regardless of BRCA status, had some degree of improvement as far as these groups were concerned.
Yeah, and it's a challenge, right? Because we had the treatment indications, that was pretty simple. But these platinum-sensitive recurrent maintenance indications are complicated because you could use bevacizumab.
Correct.
Right? And so not only do you have to choose which PARP inhibitor in platinum-sensitive maintenance, but you also have to basically sort of triage bevacizumab. How do you make that decision in, let's say, second-line platinum in the sensitive space as you described, bevacizumab or a PARP inhibitor?
You know, I think it's a really important conversation to have with the patient right at time of diagnosis of recurrence. I know it's a lot to talk about, but I think it's really important for patients to feel empowered and to feel aware of what their treatment is going to look like.
Shared decision-making, I love it.
Exactly. But that being said, there are some patients who may be candidates for bevacizumab greater than others. So for example, what is their pattern of recurrence? We all know those patients who come back with significant ascites or pleural effusions. And I think we can both agree that bevacizumab certainly plays a role in drying up those effusions. So for those patients, I would certainly consider starting them on bevacizumab to begin with. For patients who may be asymptomatic or for whom they have not yet seen a PARP inhibitor, they didn't get that in frontline, which we'll talk about in a while, I would certainly also consider doing a platinum doublet to be followed by PARP inhibitor maintenance. So in other words, after they've completed their chemotherapy, if they've had that partial response, then to start them on their PARP inhibitor at that time.
I love it. So 3 treatment indications for PARP inhibitors, and there's a bevacizumab treatment indication with chemotherapy, or in the platinum-sensitive maintenance space, 3 PARP inhibitors in maintenance or bevacizumab. See, now it's getting fun, right?
Yes.
But the most important opportunity to impact a patient's trajectory and outcome and maybe even survival is frontline.
Absolutely.
And so we like that. And so the first targeted therapy to get approval was in June of 2018. Again, it was bevacizumab. It improved progression-free survival for 6.2 months. You can say, well, that's not very much. You're right. The hazard ratio was 0.62 also. But at least it was a start. And the bevacizumab was given with chemotherapy, after surgery, and in maintenance for 15 months. And we kind of liked that, and we were off to the races. And then we had this study, SOLO-1, frontline PARP. So tell me about SOLO-1.
So SOLO-1, again, was a study for patients who had had response to their platinum. But for these patients, they had to be BRCA mutants, so either germline or somatic BRCA mutants in order to enroll in the trial.
First line.
Correct. So if they had responded to their platinum-based chemotherapy and they were a BRCA mutant, then they could go on this trial. This was another placebo-controlled trial. And these patients were treated with olaparib for 2 years if they had no evidence of disease, the completion of their chemotherapy, or if they had stable disease, they could continue on the olaparib at that point. But this showed a profound and just dramatic, unlike numbers we've ever seen before, improvement in progression-free survival.
I think at this point, that's the 7th indication for PARP, 3 in treatment, 3 in platinum-sensitive maintenance, and 1 frontline in BRCA. I think it's good to stop now and talk about the adverse event profiles, because I think that's sort of the opposite side of the coin. What's the side effect cost to the patients? Tell us about the side effects of PARP inhibitors.
I think that the most common side effects that we've seen in 3 major toxicities, fatigue, GI, and cytopenias. The good news is that though in these trials, the majority of patients may have had a toxicity, and many patients required either dose interruption or dose reduction, there were very few patients in the trials who had actually come off of the therapy related to their toxicity. So the good news is that patients should be able to stay on these medications, and especially in the recurrent setting, that could be for many years.
That's right. And with supportive care, with antiemetics, antidiarrheal medications, maybe even occasionally a blood transfusion for the cytopenia. I think 2 things are clear. One is that these are not the same drugs. They have different side effects, although subtle. Even different schedules. Niraparib is once a day, and maybe that matters. And also, the quality of life in these randomized placebo-controlled trials, when managed, there was no decrement in quality of life. So maintenance had to be convenient, and oral is. It had to work, and it does, and it had to be tolerable.
Absolutely.
So we have kind of hit the trifecta, if you will, in maintenance therapy in ovarian cancer, both in the frontline and in the recurrent setting, and it's PARP and Bev. Okay. So that's been a fun journey. Now there are 3 other frontline trials, just what you said beyond BRCA, right, that show that there's HRD activity, and maybe even like in platinum-sensitive maintenance, that there's an all-comer opportunity. So tell me about the first of those studies. Let's just call it PRIMA, because the first, and that is. And tell us about the clinical trial design of PRIMA. And by the way, all three of these studies were published in the same issue of the New England Journal, and all three of these studies likely have or will be submitted for regulatory approval, and we don't know what the labels are, but I think it's important to familiarize our audience with what's around the corner. So tell us about PRIMA.
Sure. So PRIMA is another frontline maintenance trial looking at niraparib as the agent of choice. This was a placebo-controlled trial also. And the patient population, I think it's important to note that these were very high-risk patients.
Right.
So these were patients with stage 4 disease, those who required neoadjuvant chemotherapy, those who had suboptimal debulkings. These are absolutely patients who unfortunately have poorer outcomes in general. These patients could enroll regardless of BRCA status. So patients who had homologous recombination deficiency or who even were wild type were candidates. They did not require a BRCA mutation. And the statistical analysis for this trial showed that there was a statistically significant improvement in progression-free survival. The primary outcome group was actually homologous recombination defective group, or HRD group. And in that patient population, there was a statistically significant improvement in progression-free survival in those who received niraparib versus placebo.
Clinically meaningful in the HRD population, primary endpoint, and statistically significant. So PRIMA is impactful. It obviously will lead to some sort of PARP maintenance alone, like olaparib in SOLO-1, but beyond BRCA. And the degree of beyond BRCA indication for PRIMA will depend on the FDA's perspective. Because as you go from BRCA to HRD to HRP, or molecular signature negative, there's a fall off.
Absolutely.
And so you have to weigh that. So,
same thing that we saw, though, in our recurrent platinum-sensitive recurrent maintenance trials. Very similar decrement and improvement in progression-free survival, but still statistically and potentially clinically meaningful.
let's talk about the next trial. The next trial is called VELIA. The interesting thing here is maybe we can do a PARP inhibitor and chemotherapy together and then continue the PARP inhibitor in maintenance. Kind of like that idea to see if there was some synergy because chemotherapy was damaging the DNA and the PARP inhibitor was also preventing its repair. Tell me a little bit about VELIA and what your perspective is on that very uniquely designed study.
I do believe that it is also an interesting study. Previously we were unable to do combination trials with PARP inhibitors plus chemotherapy because of the combined bone marrow toxicity. And so there are some characteristics of veliparib that perhaps allow it to be combined with chemotherapy. One of the things is that it's a much less potent PARP-trapping PARP inhibitor, so perhaps that mitigates some of the marrow toxicity. But that being said, when you look at the trial arm specifically that was treated with chemotherapy plus veliparib followed by veliparib maintenance versus those patients treated with chemotherapy alone, there was, again, a statistically significant improvement in progression-free survival, and that was for all comers. Patients did not have to have a BRCA mutation.
Yeah, the statistical design of VELIA was, first BRCA and then a step down to HRD. The hazard ratio in the BRCA group was 0.44 versus 0.30 in SOLO-1. You already told us that you can't cross-trial compare, and you told us that the populations are different. And remember, in VELIA, the time starts from the beginning of chemotherapy rather than PRIMA or SOLO-1 where it's the end.
Correct.
So I think it shows that VELIA, the fourth PARP inhibitor now, has activity. And also the second now endpoint of VELIA was the intent to treat analysis, just like PRIMA, and that was also an intent to treat. And interesting, it was about 6 months, very similar to bevacizumab. So I don't think that you can say, oh, I'm going to use bevacizumab, it's better, because it's 6 months in VELIA and it's 6 months in GOG 218. So it really creates a lot of conversation. What you said, you have to empower the patient to make this decision.
Absolutely.
So I think it goes without saying, why don't you just do both? Monk, you're telling us bevacizumab versus PARP inhibitor. Well, why don't you just do bevacizumab with chemotherapy and maintenance and layer the PARP inhibitor over it? And they did, and that's the third study in the New England Journal. and that study is called PALLAS. So tell us about those endpoints.
So the PAOLA trial, is looking at the use of bevacizumab with or without a PARP inhibitor. And so the question is, what happens, number one, with progression-free survival? So in this patient population and the intent to treat group, there was an improvement in progression-free survival, again, statistically significant. It's interesting, there were some exploratory endpoints looking at how well subgroups of patients did. And some patients, perhaps performed better, those BRCA mutants, versus those patients who were wild type, those proficient patients. They really did not seem to have a significant degree of progression-free survival improvement. And the other thing is, obviously, when we're combining bevacizumab with PARP inhibitors, there are very different side effects or toxicity profiles. And so I think it was good to look at and evaluate to see if those additive toxicities were too significant for patients to tolerate, and it did not appear to be that way.
One of the things that's interesting to me with PALLA is that there was an active comparator. So all of the other maintenance trials, the 3 in recurrence and the other 3 in frontline, right? SOLO-1, PRIMA, and VELIA all had placebo, but here you having to beat something. I get it's 2 medications versus 1, but that makes it very difficult to compare. So we talk about medians, median progression-free survival, or should we look at hazard ratios, which is really the comparison of the curves?
I think we don't know which one is better. It's a hard question to answer, but I think in my mind, I am more of a hazard ratio person. It's allowing us to better understand the relationship in impact of therapy when comparing a group, as opposed to the median survivals. I just think that hazard ratio gives you a better idea of how these two groups compare with one another.
Right. I like what you said just yesterday. You said, look, Brad, that if it's a high-risk population, then the medians may not be very different because the patients do poorly. But if you enroll a good prognosis group of patients, then the numbers are big, and even a small hazard ratio may yield a big median. So I like the hazard ratio, but patients don't. You tell a patient that, the intent to treat in VELIA is, 0.68, and they're going to go, what?
Right.
And so we have to message that in a very impactful way, and it's challenging.
It is. I mean, I think for patients, the things they want to know are, am I going to be able to go to my son's graduation?
I know, right?
Am I going to be able to enjoy going for my hike without feeling too tired?
Lose my hair.
Correct.
Neuropathy.
And, what can I expect as far as outcome? And so for them, I think probably it's a little bit more impactful to discuss general differences in how the groups behave. Talking to them about specifics, about hazard ratios or trial design, usually it's going to be a little bit beyond their interest. But that being said, it's important for us as practitioners to understand, because it will help to guide our differences in how we're going to treat patients, help us to hopefully choose a little bit better.
I've kind of learned that there's 2 key decision points as we treat newly diagnosed advanced ovarian cancer. One at the beginning of chemotherapy and one at the end. I think all these patients get carboplatin paclitaxel. I think we've learned that it's an every 3-week carboplatin, generally an AUC of 6, maybe 5, and a paclitaxel dose, generally 175 milligrams per square meter over 3 weeks. But that first decision point is bevacizumab, yes, no. And if VELIA gets approved, veliparib, yes, no. Added to chemotherapy. How are we going to make that decision?
Well, I would say for me, when I am treating my patients who have high-risk disease, and this is based on sub-analyses of other bevacizumab trials, so those patients who required neoadjuvant chemotherapy, or who had stage 4 disease, or who had suboptimal debulkings, those are the patients that I typically would consider for bevacizumab, and I don't really anticipate that changing much for me in the future. And then the question is, will we have the opportunity to then perhaps add some sort of maintenance to the bevacizumab maintenance? But as far as that upfront decision tree, am I going to give bev, yes or no? It's really those high-risk patients that I've been utilizing it.
The other thing is you don't have all the molecular testing back.
Correct.
So in the beginning, those patients need treatment immediately. You don't have the germline BRCA or the panel, and you don't have the somatic BRCA or the HRD status. So over time, I think, as they get the 6 cycles with bevacizumab or even veliparib, you will get this molecular testing done, and then to the second decision point. So first, as chemotherapy starts, and then second, when chemotherapy is finished. So if you get a patient, let's say, that has a BRCA mutation, and she's on bevacizumab, would you add olaparib to the bevacizumab, or since olaparib works so well in SOLO-1, just give the olaparib alone?
Excellent question. I think that for my patients who I have started on bevacizumab, I would like to continue them on bevacizumab and then add the olaparib if that's an opportunity. Again, the SOLO-1 patients were not really those very sick patients.
That's right.
And so it's hard to extrapolate the data to them. I'm sure that they will, and obviously we now know from Paola that those patients benefit. But my preference would likely to be to continue the bevacizumab and add olaparib if I can.
Yeah. One of the toxicities we haven't mentioned is acute myeloid leukemia and myelodysplastic syndrome, which is 1 to 2% and can be lethal. So that always looms sort of over people's heads as they begin a PARP inhibitor. Quite frankly, if you are BRCA mutated, you need a PARP for sure.
Yes.
And whether you get Bev or not maybe doesn't matter so much. And maybe that's the same thing if you have HRD. You need a PARP inhibitor, and whether you get Bev or not, it probably doesn't matter too much. I think the most difficult patient population is the HRP. So let's go back. You start your bevacizumab, she's homologous recombination proficient, no molecular signature. You gonna add a PARP inhibitor to that or no?
I don't believe so.
Same, right? Because the data just doesn't really support it. There might be some patients who get chemotherapy, Bev, and maintenance who respond to platinum again, and that really is maybe the best biomarker, and then you can give a PARP inhibitor and maintenance then, right? So I think that's okay. If I don't do any Bev and she's HRP, as the data matures, I might give niraparib. This whole philosophy out there that maybe niraparib is a stronger PARP trapper, although I'm not really sure. I also want to comment on this homologous recombination proficient subgroup. Clearly, PARP and Bev didn't really fix that opportunity. We're eager to see if IO, specifically atezolizumab, fixes the HRP problem. And so we have a atezolizumab bevacizumab study, which will mature in 2020, called Imagine 50, that you and I participate in, and that's probably what you can expect next. I get it that bevacizumab and checkpoint inhibitors are coming, but I'm kind of excited about checkpoint inhibitors and PARP inhibitors. So tell us about this study, ATHENA, that kind of capitalizes on this idea where you give the 6 cycles of carboplatin paclitaxel and then have an opportunity for a PARP inhibitor and a checkpoint inhibitor.
Yeah, so it's an interesting concept. The idea here is that perhaps PARP inhibition may upregulate some of these immune pathways, and then the use of an immune checkpoint inhibitor also, of course, is going to upregulate immune pathways. So if we use them together, can we make these drugs more effective? So ATHENA is another maintenance trial looking at the use of nivolumab and rucaparib. So either rucaparib alone, nivolumab plus rucaparib, rucaparib alone, or placebo. So there are 10% of patients that are going to receive placebo on this trial, which is, an important thing, I think, to evaluate how well the patients do without any medication at all, and then be followed to see how they do as far as progression-free survival.
Yeah, so this study is done in enrollment here in the US. It's about 3/4 enrolled internationally. So I think this will be an interesting concept. We have a pretty good understanding of bevacizumab and PARP. We really have no idea of bevacizumab and checkpoint or PARP and checkpoint. So combinations are coming, and I think the real opportunity is in these molecularly signature negative patients, these HRP subgroups, and see if we can really overcome this place where PARP inhibitors don't work very well.
Right. Yes, if there's some way that we can perhaps augment and then allow them to be more PARP sensitive.
There you go. And there's phase 2 data to support that, right? There are platinum-resistant settings where neither PARP nor IO work, but when used in combination, there have been some exciting response rates.
Yes, absolutely.
It's been 5 years since the first PARP inhibitor got approved in treatment, and it was approved in heavily pretreated subsets of patients. Having said that, all of those patients were treated with chemotherapy, and you got to have an opinion and hear as patients inherently compared their PARP inhibitor to the paclitaxel, the carboplatin, the liposomal doxorubicin, gemcitabine, topotecan, and other medications they had received. What do patients say about being on a PARP inhibitor?
You know, I have seen some patients who feel like they're not even on any medication when they're on their PARP inhibitor. But I will tell you that the majority of my patients do have some symptoms, and these usually occur early. So many patients do have this fatigue. Sometimes it's not overwhelming, but it can be bothersome, and many patients report nausea. So as you said earlier, I think it's very important to prophylax against certain toxicities like nausea, have them fill their antiemetic and even take it before they use their PARP inhibitor, or perhaps select a once-a-day PARP inhibitor that you can give at night. As far as fatigue, you know, I warn patients that they may feel tired, and it's important to allow them to resolve from their chemotherapy toxicities before you put them on their PARP. So this does not mean you get cycle 6 of your carboplatin paclitaxel and then 1 week later you're starting on your PARP. It means you need some time to feel better.
I think communicating to the patient that just because you get a dose reduction doesn't mean you're going to increase your risk of recurrence and death. I think that sometimes they're so afraid to tell you because they're afraid that you're going to reduce the dose.
Right.
So I think by messaging that dose reductions are okay and are expected probably will help the quality of life trajectory.
Absolutely, and you know, obviously we understand that that's part of trials and trial interpretation. Those patients on the trial had to have dose reductions, and as we talked about before,
The outcomes are what they are.
yes, like the intent to treat analysis, it includes those patients who had dose reductions. So that I think helps hopefully to allay some of the fears that patients have. But that being said, in general, patients certainly seem to prefer oral medication over chemotherapy.
No alopecia, no neuropathy.
Yes.
And that resonates with me because that's what I hear in the office. Any closing thoughts if we've sort of discussed PARP treatment, PARP maintenance after sensitive response, frontline PARP in BRCA Solo 1, and then the new opportunities with Prima, Villi, and Pala? What are your closing thoughts?
I think that the most important things that I would like practitioners to consider or to remember is, number one, the importance of testing. So testing needs to be done. We still in the United States are not doing it enough.
Germline and tumor?
I think that both are important.
Yeah, me too.
And I think it's important for a number of reasons, including potentially impacting the way that you're going to sequence your treatments, just like we've discussed, as well as hopefully preventing cancer in patients' family members. But that being said, I also think that hopefully all of our ovarian cancer patients will have the opportunity to have a PARP inhibitor at some point along the course of their therapy. So that may be for some in the beginning. For others, it may be in the setting of a recurrence in the form of maintenance, or for others, it may be in the form of treatment for recurrence. But I think all patients diagnosed with ovarian cancer today should have hopefully the opportunity to have a PARP inhibitor as part of their treatment in the future.
And I would even expand that, maybe even PARP and Bev, right? Because bevacizumab is also an important medication. I think the sequencing and the combination really is what is evolving. So this has been a lot of fun for me. I want to thank you taking time away from your busy schedules. I hope you found this informative and useful, and it impacts your practice as you impact your patients. So thank you, and so long for now.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.